Now next we have Dr. Prithvi Chandrakanth, who's a vitreoretinal surgeon at Dr. Chandrakanth Netralia Kozhikode, and he'll be talking to us on diabetic retinopathy essentials for the general ophthalmologist. Over to you, Dr. Prithvi.
At the outset, I would like to thank Dr. Shishir for this opportunity and KSOS also. I'll be talking about diabetic retinopathy essentials. Just for a introduction, it's a chronic progressive sight-threatening disease of the retinal microvascular associated with prolonged hypoglycemia and associated with other conditions such as hypertension. Just a small brief on epidemiology. So type 1, that's insulin dependent, is 70%, non-insulin dependent and is 39, and type 2 with insulin is 70%. The prevalence, as you can see, the type 2 is almost 90% of diabetic patients, and the most common cause of legal blindness between ages of 20 and 70 years. The risk factors that we need to know is about the duration of diabetes, poor control of diabetes, hypertension, nephropathy, obesity and hyperlipidemia, smoking and pregnancy. So duration of diabetes is the best predictor of diabetic retinopathy, and a patient diagnosed with diabetes mellitus before the age of 30 years, the incidence of DR after 10 years is 50% and around 90% in 30 years. And after 20 years of diabetes, nearly 99% of patients with the type 1 and 60% with type 2. Poor glycemic control. As you can see, the diabetes control and complication trial have showed that the risk of developing retinopathy is 76% reduction in intensive control and slowed progression of retinopathy by 54%. The UKPDS also gives a similar consensus, and the target HbA1c should be between 6.5 to 7%. So pregnancy is sometimes associated with the rapid progression of diabetic retinopathy, and the key factors are greater pre-pregnancy severity of retinopathy, poor pre-pregnancy control of diabetes, control exerted too rapidly during the early stage of pregnancy, and development of preeclampsia and fluid balance. So the hypertension, and it's given the ABC trial that target BP should be less than 140 by 80, and the Euclid gives us showed the lower rate of development of retinopathy in diabetes taking lisinopril for antihypertensive medications. In nephropathy, if severe, is associated with worsening of DR, and conversely, treatment of renal disease may be associated with improvement of retinopathy. Other factors are smoking, male gender, hyperlipidemia, cataract surgery, obesity, anemia, carotid artery occlusion disease, and questionable about alcohol. Basically, what is happening there is the microvascular leakage because of loss of pericytes, which results in distension of weak capillary walls and producing microaneurysms. Also, the blood retinal barrier breaks down, causing plasma concentrations to leak, and ultimately causes retinal edema and hard exudates. The basement membrane thickening happens. The endothelial cell damages, deformed RBCs, platelets thickness, and aggregation is the other factors. Finally, what happens is vascular endothelial growth factor is produced by the hypoxic retina, and which stimulates the VEGF, the growth of shunts and new vessels. This is a small picture showing the same. So what happens in this is exactly how it looks in a defective patient's vision. So this is a small flow chart showing the same. So classification of DR is non-proliferative, proliferative, and the second thing is the clinical significant macular edema, CSME. So this is a classification from the International Classification of Diabetic Retinopathy and Diabetic Macular Edema. And what about diabetic vitreopathy? That is vitreous structures, which the diabetes induces changes of posterior vitreous, cortical vitreous, and it happens due to glycation of the vitreous in precocious synthesis. These are other classifications. Just a brief video of what are the signs of diabetic retinopathy. As you can see, the small dots are microaneurysms and dot blot hemorrhages. You can see the dot blot hemorrhages here. See the hard exudates. This is the cotton wool spots. So this is our these are the hard exudates, cotton wool spots, You can see over here the focal diabetic maculopathy, circular hard exudate with a small microaneurysm over here. The diffuse diabetic maculopathy, venous changes, that is looping, venous changes, beading, the severe segmentations, and then the ETDRS CSME protocol, in which you can see that the optic disc diameter, that is one disc diameter. So you see the fovea, one disc diameter around the fovea, and the 500 microns, that is where the retinal thickening happens. So then it is called a CSME. What if there is hard exudates that with the thickening is called CSME. This is a second classification. And the retinal thickening, which is almost one disc area, part of which is lying within the one disc diameter, is called. So this is how the IRMA looks, intraretinal microvascular abnormality. And this is proliferated diabetic retinopathy, mostly characterized by neovascularization of the disc, and elsewhere the mild form and the severe form with fibrosis over here, and finally the NVI, rubeosis iridis. Here you can see the new vessels elsewhere with fibrosis, and this is the laser marks. Finally, advanced diabetic eye disease with the tractional component, that is the tractional retinal detachment over here. You can see over here, which is completely over the disc. This is a vitreous hemorrhage. This is a tractional retinal detachment, hyperemic disc, swelling. So blindness due to DR could happen because mainly because of non-clearing vitreous hemorrhage, neovascular glaucoma, tractional retinal detachment, and macular ischemia. So how do we prevent these complications? By early institution of appropriate treatment, early detection of DR in asymptomatic treatable conditions, by routine fundus examination of all the diabetes, and appropriate referral to the ophthalmologist. So what is the treatment protocol? Mild and moderate. It is more in terms of observation. So good metabolic condition control needs to be done, and it delays the progression, and control of associated hypertension, anemia, and renal failure. Severe and non-severe, very severe needs to be closely followed up. Can also plan on scattered PRP. CSME, so you take a OCT and find out what are the diabetic macular changes, and what are the biomarkers, and we can actually plan on injections. If it's more chronic, you can actually plan on something like a steroid implant like Ozurdex. And if it's a non-central involving, you can always plan on a focal laser. So proliferative diabetic retinopathy is more well handled by retinal laser photocoagulation. It converts the hypoxic retina into anoxic retina. This is again the referral to the ophthalmologist. Visual symptoms, anything which has any patient has a diminished visual acuity, seeing floaters, painful eye, can be referred. Fundus findings, macular edema, hard exudate close to fovea, and proliferated DR with VH, moderate to severe and severe NPDR retinal detachment, and cataract obscuring the fundus view. So diabetic papillopathy can be unilateral and bilateral. It's a mild form of non-arteritic ION, and a painless mild decrease in visual acuity, and it improves with anti-VEGF and steroids. So a lot of other studies, landmark studies, the DCCT, which tells that the intensive treatment 10 times more effective than the conventional, and HbA1c should be monitored well. And then the UKPDS, again telling us the reduction of incidence and progression risk from smoking could be accounted for lower blood pressure. And the ETDRS, the classification that we have got, we are still using the same. The DRS, which gives us that the panretinal photocoagulation is efficient for us to manage PDR cases. Just a small brief on PRP techniques. We usually keep a one disc diameter away from the arcade vessels and the disc, and temporarily at least 3 disc diameters, and give a photocoagulation. Should have at least a one burn apart PRP lasers to be done, and can do it within 2 sessions or 3 sessions. I do it more in 3 sessions with at least 1,000 spots in a session. The first one to go is the inferior retina, and then the other parts. avoid blood vessels and hemorrhages, and also the tractional components, the fibrous proliferations. Complication of lasers are vasovagal attack, reduced contrast and color, peripheral vision loss, decreased night vision, CDs, exudative RDs, and pre-retinal hemorrhage membranes. So indication for diabetic vitrectomy, any non-clearing VH, any tractional RD involving the macula, combined RDs, progressive vascular membranes, refractive DME with attached posterior hyaloid, macular tractions, opacified posterior hyaloid phase, and eyes with reviosis and media opacities. All these cases can be taken up for vitrectomy. Again, OCD biomarkers, just want to say that these are all the positive ones and the negative ones. The positive biomarkers will give you a good prognosis. Negative ones won't give you much of a prognosis. So we'll have to explain to the patients looking at these biomarkers whether their vision is going to be improved or not. Again, the ones with better visual outcomes, you can also see with if it's chronic, and if it's chronic, you can plan on other steroid implants. Thank you.